Rosella Vlasic, and I'm the director of the Alaska GEC. And the Geriatric Education Center is funded by the U.S. Department of Health and Human Services, Health Resources and Service Administration. We've been designed to train healthcare professionals in the area of geriatrics. And it's through HRSA that the belief, and again supported by evidence, which is data, is that we can get at increasing the quality of care, especially to medically served individuals, through education and training of healthcare professionals. And so today, as I said, is a somewhat new line of training for us with respect to looking at simulations as it relates to case studies, and using case studies based around actors and actresses so that we can really show you how an interprofessional or interdisciplinary team interacts with an older person. You know, the U.S. Department of Health and Human Services is very much aware and really of the high cost of health care. And so one of the other areas that is really important is to look at the effectiveness of interdisciplinary teams. The physician working with the social worker with the nurse, and the nurse and the clinical psychologist, and a physical therapist, and an occupational therapist. So today we're very excited because Texas and our colleagues at Texas, I think, are leading the way with respect to clinical simulation as it relates to case studies. So I also should make just a quick comment for you. Because we are federally funded, we are mandated to collect information regarding the people who attend our trainings. Subsequently, what you hopefully have already received is through email the Survey Monkey of our participant profile form. So I want to thank you for filling those out. They're very important for our data collection. When we do report that, your data is not affiliated with your name. It goes in, is an aggregate group type of data. And also, in addition to that, what you'll be receiving, and that's if you supplied us with your email, is you'll be getting this afternoon the evaluation set up on SurveyMonkey. And we would certainly appreciate if you could take a few minutes out of your busy schedule to fill out that evaluation piece. Now, just a quick check of the Alaska sites again. Is there any difficulty in hearing me? Sitka?
No, we hear you fine.
Okay, thank you. Is Fairbanks online yet?
We're here, but there's nobody here but us.
Okay, thank you. The Alaska Rural Telehealth Network, I was told there may be 3 sites, but it looks like there's only 1. Where are you emanating from?
Rifle Medical Center.
Okay, is anyone from Cordova on or Sitka? Okay, thank you. If there's no difficulties in hearing me, now we're going to mute ourselves. And Tony, I'd like to have the director in the Texas GEC introduce themselves, and the Texas Medical Branch and their AHAC that is co-sponsoring this event, and he'll introduce the individuals who are participating, and then we'll also, as I said, kind of give us an idea of when, as an audience, we can participate in the case study. I'm muting this now, Tony.
Very good, Rosellen. Thank you so much. I was very thrilled when I received a call from HRSA to see about collaborating with the Alaska GEC to establish and do a standardized patient program here through UTMB and connect with sites in Alaska. I'm Tony Danuzzo. I'm director of the East Texas Geriatric Education Center. We do the same thing that Rosellen just said in Alaska, except that we do it in Texas. It's the same mission with HRSA in terms of training health professionals in geriatrics to improve the possibility of health outcomes for older patients. I'm not going to take a lot of time because Karen has a lot of great things to talk about and to show us. So I want to just go through a couple of slides here, and then I'll get an idea of who we have. Okay. So we're teleconferencing the 4 sites in Texas, Lamar University in Beaumont, Stephen F. Austin State University in Nacogdoches, Baylor University in Waco, and Victoria College in Victoria. And I also put on this slide our AHEC partners. It's very crucial for us to have this partnership with AHEC because they connect our programs with our large area that we're trying to cover. And we have Terry Dickinson over in Lamar University of Coastal AHEC, Mark Scott with Piney Woods, Stephen F. Austin in Nacogdoches, Amanda Woods at Baylor University with Brazos AHEC, and Jody Sanders with Pecan Valley and Victoria College. Also like to acknowledge Robin DePine for Victoria and Pecan Valley AHEC. I just want to go through to see real quick if you can hear us. And okay, so on the top corner, top right corner is Pecan Valley, Victoria College. Everything sound good and look okay? All right.
Yes, you're good.
Okay. Let me know if you need to increase volume at all. All right. Below that, I think was Lamar University. In the center there on the right. Volume okay? Everything look and sound good? Know how to use those? Got those mute buttons.
So we look for
okay. Okay.
I believe.
Very good. All right. And then Stephen F. Austin in the bottom right corner. We got there. Somebody just voice acted there.
All the speaker mute is not showing up there, so.
Do we have Baylor University connected? All right, well, we have 3 sites in Texas. There's also lots of information and handouts that we've been giving out, and we have information on websites that are available. They might like to see more information there. I'd just like to introduce Dr. Karen Sauter. She received her MD degree in Case Western Reserve University and residency in internal medicine there, and fellowships in gastroenterology and nutrition. She's a senior medical educator in the Office of Educational Development and medical director of the Standardized Patients Center. She's also full professor in the Department of Internal Medicine and Gastroenterology, and she worked with the standardized patient staff to ensure that the medical aspects of this standardized patient cases and portrayals are accurate. She coordinates projects and research in the SP Center, and her areas of interest, in addition to the SP, include teaching, evaluation, professionalism, and professional development.
Great. Well, good afternoon, everybody, and thank you for this opportunity to talk a little bit about simulation, about standardized patients, and to give you an idea of some of the really exciting things that we've been doing here at UTMB for many, many years. What I would like to cover in the beginning of this presentation is to talk to you about standardized patients and some of the activities we've done with the SPs and with simulation. Not all of this is directly going to focus on the geriatric patient as I talk about the overview, but the idea would be to start getting you thinking about things that you could be doing with patients regardless of age, because these are all conceptual foundational ideas, and then we'll talk specifically about the geriatric program. I do have a patient with me. We will be conducting an interview as part of a demonstration. And at that point, because the groups are small, I think what we're going to do is allow routine feedback as we would in a teaching opportunity with our classroom. And so we'll be able to do this with various sites. So this can be actually a very interesting way to present and talk about this program. I work on the premise that you cannot teach experience. And I think that what we really try to focus on with the idea of standardized patients is giving people experiences. It's incredibly important that many of the things that we talk about and read about, until you've actually done them or experienced them, you don't know how well they're going to go. We are looking at a variety of things when we're talking about simulation. We're talking about a way of teaching and a way of testing that can test many things, including factual knowledge, critical thinking, psychomotor skills, and also differently than what we can do just with paper and pen, that we can also look at a learner's attitudes and values and feelings. And certainly with the standardized patient program, this is something really important to us, that we know that this, how the students are reacting to a person, much more so than the data that they're collecting. So why simulation? Well, over every year that we're in practicing in healthcare, regardless of our discipline, there's a lot more to learn. There is much less time for us to spend with patients because of the many conflicting or competing requirements for our time. There's less time for the learners to be with faculty or experts, and so we try to give them opportunities where foundational skills can be learned and then enhanced by the faculty and experts. And also with simulation, multiple learners can experience the same thing. So I know if I want every student to work with a patient who is delirious, I can set up a simulation with the delirious patient, and student after student after student can have an experience with that patient. So the most important thing with doing all of this is making sure that we're providing experience to our learners. Now, simulation globally, and globally as a concept, is not a new thing. It's very well established. It's been very well studied, both in aviation, is the example we often use, but clearly also used a lot in the military. So we start with students getting factual knowledge, or learners getting factual knowledge in a classroom. Then we put them into a hands-on system where they're learning by doing. They're learning in a simulator where they can make mistakes, but there are not devastating consequences to their mistakes. And then finally, we let them do what we hope they've been trained to do. What are the benefits of simulation? And I'll walk through these quickly, but these are really the things that we're thinking about as we're teaching with simulation, and certainly with a population such as the geriatric population. Probably the key thing I would say is it's safe. The difference between learning on a patient and learning on a simulated patient is that we can set boundaries for the simulated patient or the standardized patient. So we can set up a safe environment both for the patient and for the learner. If the learner makes an error, we can stop the simulation and start it over again. And there's no negative outcome to the patient in particular. We can set forth learner-appropriate challenges. The difference between what we want to do with a first-year medical student or a first-year nursing student and a person in a PhD program or a person in a residency program are very significant. So the challenge that we set up with the simulation, particularly with the SP, is very different. Immediate feedback and correction is vital for successful simulation. So what we're looking to do is sometimes push the learner beyond their comfort zone and then stop the simulation, which we'll demonstrate when we do the demo, and say, what would you do now, or what could we do now to make this better? How are you feeling? What's going on? So it's about the learner, not so much about the patient. We can, with large-scale testing using simulation, identify either individual weaknesses on specific areas or identify weaknesses of the group. So if we're looking at a group of learners and we expect them to have mastered certain skills, if we put them through a simulation and none of them are doing well, either our teaching hasn't been successful or the mastery, what we're trying to get across, we're not, the experiences that they've had are not manifest yet, and so we'll go back and reteach. We can challenge decision making. I'll talk about that in a moment. We can make intentional mistakes. We can set a simulation up so no matter what the student does or the learner does, it's not going to go okay. Or something can be set up so when they try to do something or try to give oxygen to the patient or try to do whatever, it doesn't work. And that's part of the simulation. It's predictable. We know what's going to happen because we've programmed it or we've planned it. It allows us to assess baseline competency, coming back to looking at both at individuals and groups. And finally, we can also stop and debrief and understand what a person is thinking. You ask the person about their activities of daily living, and he told you that he's having difficulty with bathing. And then you just moved on. Why didn't you stop? Why didn't you explore that more with the patient? That's a really important thing. What were you thinking that you skipped over that idea? So we really can stop the thought process and get the person to articulate what they're thinking. So there are multiple simulation methods, and I know that the various people that are listening to this presentation, some have mechanical simulations, full mannequins, etc. Some may have models. Some of you may have just small computer modeling, whatever. But the key things that we talk about are human simulation, which is when we're using simulated or standardized patients, models, which are task trainers and high-fidelity mannequins, computer sims, which are flat-screen computer simulations, virtual patients, and virtual reality. And what I'm going to focus on in the next several minutes is really talking about human simulation using both standardized patients or simulated patients. Just to give you a brief background on simulated or standardized patients, this is a relatively new methodology in education. The whole concept of using standardized patients was sort of conceived in the early 1960s by a physician named Dr. Howard Barrows, who is a neurologist. And the story is told, obviously has been changed over the years, but the basics is that he was working with the patient at the patient's bedside, and the patient was frustrated with the resident. And so when the resident came to do her neurologic exam, she intentionally made her toe go upward when the plantar reflex was checked. And at that point, Dr. Barrows said, well, this is amazing. I could have people do things and then check to see whether or not the residents are picking up on it and they really understand the meaning of certain findings. And that's kind of the Cliff Note version of what is said to have happened. But he sparked then a methodology which has now received international acceptance and, as many of you know, is used throughout the United States in medicine and in osteopathic medicine and chiropractic medicine for licensing exams. Used in Europe in a variety of countries and is still being used in more and more places for very high stakes licensing because the methodology of this has been worked out so well. We do a lot of work with teaching, and I'm really going to focus most of what I talk about on teaching because I think that's the rich place and really the place where the geriatric population is wonderful to work with in helping the students overcome some of their anxiety, some of their misunderstandings, some of their misconceptions. Our program has been in place at UTMB since 1971. We serve the School of Medicine, the School of Nursing, the School of Health Professions, and graduate education programs, including some of the residency programs at UTMB. In our program, we have over 1,000 learners come through the program every year. We send SPs out, the students come to us, but we really do reach out and interface with a lot of people, which is loads and loads of fun. So what is a standardized patient? Well, the definition of a standardized patient or a simulated patient is a lay person who's been trained to portray a person with a specific health problem or a specific health concern. So the important thing is that we take people from all walks of life. SPs are people from our own community. And when we work within our SP program, the people that we're recruiting to be SPs are representative of people who live in our community. We do a lot of verbal communication with the community to get people to come into the program. But as you can see, we have young people, we have geriatric people in our program. Right now, our oldest standardized patient is 85 years old, and she's still working actively with us, as opposed to our youngest patient right now, who is about 11. So we really do cover the breadth of late childhood. We're not using little children, although some people do, all the way through adulthood and geriatrics to really get the full flavor of issues across the life cycle. So we do two main activities with standardized patients, both teaching and assessment. I'm going to talk about teaching because I think this is where, particularly as you're coming up with new ideas and new things that you might want to do with standardized patients, some of the techniques that we talk about in teaching and some of the formats that we use for teaching can be really valuable to think about. In the very beginning, we'll teach basic interviewing skills using standardized patients. So our medical students start working with standardized patients about the 3rd week of medical school. And it's with standardized patients that they learn to introduce themselves in their new role as a healthcare provider, and they begin to learn the technique of the medical interview. Once they start to master the history of present illness and the past medical history, they'll start going through more and more comprehensive interviews with the patients. We have something called a timeout feature, and we're certainly going to demonstrate that when we do this. But one of the nice things about using the standardized patient in the classroom is that the student can be interviewing the standardized patient with a group of learners seated around. At any point, if the person who's conducting the interview feels uncomfortable or doesn't know what to ask next, or really doesn't know how to move the interview ahead, they just call a timeout. And for purposes of describing this to the students, we tell them at that point the SP essentially goes into suspended animation. You can talk, you can ask anything you want, and it's as if the SP is not there or your patient is no longer there. So if I get halfway through an interview and I no longer know what to say as an early learner, or it's an area that I'm not comfortable with, I stop, I turn to my colleagues and I say, what should I do now? They give me feedback, we make lists, we use boards, and then we time back in and we continue the interview. So it lets you challenge the learner with something that they might not necessarily be comfortable with, but with a group working together, and particularly with an interdisciplinary group. You can get a lot of really interesting and valuable ideas about where to approach the patient and what next steps need to be taken in gathering the history, what steps we will do when we perform the physical exam. We also use standardized patients extensively for teaching the physical examination. The beauty of the standardized patient, unlike a patient who comes to clinic or unlike a patient who is hospitalized and is not feeling well, is that learners can keep practicing on the standardized patient until they achieve competence. So if a student doesn't know how to do the cardiac exam or a student doesn't know how to elicit reflexes, the SP goes to the classroom and the student can continue to practice until they feel like they've mastered the skill and can move forward. The SP can also provide feedback to the student. So for example, in palpation of the lymph nodes, which you see in this picture, the SP can say to the student, your fingers are not in the right position. You're not pressing hard enough. If I had lymph nodes, you're not in the right place to feel them. And so this allows us, again, using a standardized patient sort of in both in a role as someone for the students to practice with, but also can serve a variety of roles as a teacher. Also incorporated in the basic physical exam is teaching the student how to tell the patient if they have a physical finding. So we actually do use standardized patients who have actual physical findings. All of our standardized patients have a head-to-toe physical before they start working with us. We know all of their abnormalities. We know if they have any unusual heart sounds or lung sounds. So we can actually put a patient in, have the students listen, and then have the students tell the patient what they've heard to verify that they are or aren't picking up a physical abnormality. So again, sort of closing the loop on both practice and communication skills. Terrific. So I want to shift now and talk about, to get you thinking and to start your creative flow, is the very basics of the interview, the very basics of the physical exam. But the beauty of doing this is pushing the envelope. We good, Tony? Okay. So as the students have sort of mastered the fundamentals, we put them through more challenging interviews. And those challenging interviews are going to be, for example, scenarios with emotional complexity. So they still have to gather data from the patient. They still have to perform the interview. But the patient might be angry. The patient might be anxious. The patient might be frustrated with the medical system and lash out at the learner the first moment they walk into the room. And it goes on. We have about 10 or 15 different emotional overlays that we'll put on cases to verify that the learners can both get information with a patient who's not just typical cooperative, friendly, interfacing patient. We also do difficult content. One of the cases that we do is we use a patient who's chronically ill, who's not managing her health care well, but she has limited education and social resources. And so it's, how do you get the point across to the patient that her illness is taking a toll on her and verify that she can actually understand what's going on? We use standardized patients for teaching and letting students practice the very challenging skill of delivery of bad news. Telling a patient whatever it is that needs to be told, all the way from a new diagnosis to a terminal diagnosis. And again, these are all things that we've done both with adult patients, with adolescents, and with the geriatric population. We do interviews using interpreters, and one of the things that this particular moment represents is that this interview, which involves a nurse and a physician, is being done with a family who one of the family members speaks English, the other one does not. And so all of the interview is conducted, and then the person who is the bilingual patient then translates to the non-English speaking patient and translates back again. And this is done in a large group setting where all the students can see what's going on, and then the class is debriefed and there's a lot of discussion. It's a challenging interview in that the two people are actually husband and wife, and they're not agreeing on the plan of care for their child. So it's both the complexity of the cultural issues in the parents not agreeing and the language issues that are introduced. And again, we do this both with children and with adult children of an older patient when there's the same type of a scenario. Challenging interviews are also done where we'll have discussions with the family member where the patient is not present. The two on the left side of your screen is a very intensive discussion with two adult children when their mother is exceptionally ill. And it's the social worker or the nurse or the physician having to speak to them and explain what's going on. The other one, as you can see, is a mother with her adolescent daughter when she brings the adolescent child into the clinic and there are issues. And again, the doctor has to speak to both. How do you balance who you're speaking to and who you're conveying the news to and addressing the news with? At UTMB, we have a very unique educational environment, is that we have a maximum security prison hospital here on campus. And so one of the challenges is helping learners learn how to interface with a person who is in shackles, in handcuffs, who has an officer with them when you have to do an interview. And so we've actually used a case where this is one of our standardized patients, and we put them in a situation where they are having issues that would be influenced by the way the person can gather the history because they are an inmate of the statewide prison system. In addition to more challenging interviews, we also do more challenging physical examinations. And we use a group of patients who then go through extremely specialized training to be teaching associates. We've used extensively our teaching associates to help people learn the female breast exam, the female pelvic exam, the male genital exam, and the male prostate and rectal exam. Again, we have people who have gone through training. Many of the men who work for us are older men who actually, many of them have prostate findings, and so the students, when they're learning to do the rectal exam and the prostate exam, the standardized patient is giving the student feedback on what they're feeling, which is going to be a rare thing for a student, but it really helps increase their confidence to know that they're doing the exam, an internal exam, correctly. And so this is another way we use our patients. We also use SPs as teachers to teach the students, you're about to do a pap smear on me, this is how the pap smear is done, this is the equipment you're going to use, and they actually play an important role in teaching. We've just gotten a grant to train several standardized patients to be standardized patient teachers for the foundational physical exam skills. And so it will be possible now for very early learners to come in and go through the physical exam and get intensive, correct feedback from lay people who are now specifically being trained for this purpose. I'm going to shift a moment and talk about assessment, because that's something that we know both from the licensing exams, and it's something we do a lot of here using standardized patients. SP assessment can be discipline-based, and it can also be multidisciplinary, and it can also be interdisciplinary. So creativity only stops when you stop thinking about what we do in clinical practice, because essentially we can model anything with SPs. So in a standard multi-station assessment, students go from room to room either seeing one discipline, so for example, internal medicine, all the patients are going to have internal medicine problems, and the students will go and see someone with a chest problem, someone with an abdominal problem, someone with a DVT, etc. Or they can go into a higher level, a senior exam, where all the patients are any discipline. And so if they've taken psychiatry and surgery and OB-GYN, etc., there can be anything in any room. They don't know if it's going to be a pediatric case or a psych case or a surgery case. That information is posted on the door, so they get just a little vignette that might say, you know, Ms. Marcia Smith is a 27-year-old woman who presents to the clinic today with lower abdominal pain. Her pregnancy test is positive. Go in, perform a medical interview, appropriate physical exam, and then they come out of the room. The patient is serving as an evaluator, so they are scoring the student on their on a checklist that they have. And then we get the feedback as the faculty on how the students have performed. We give the students feedback. Some of these are very high stakes exams. The students have to pass these to get through the class or medical school. Others are solely for formative feedback. In all of our assessments, we're very careful because we want to make sure that we're covering the life cycle. So we do have many patients over 65 who work for us in the standardized patient program, and we always are sure to have several geriatric patients working for us so that we can test and assess student skills specific to geriatric medicine. The original assessment exercises were very short. They were called the OSCEs. They were 5-minute go in and perform a heart exam. These have really evolved now into clinical performance examinations where the students go in and do virtually everything you would do in a clinic visit in a very short period of time. We can assess content knowledge, we can assess interpersonal skills and communication skills, we can quickly assess their ability to pull it all together. So this is actually a really nice format as opposed to the teaching where you're doing a lot of stop and start with the students to see whether the students have mastered skills in a formalized setting. So standardized patient exams are widely accepted. They're used all over. Most medical schools in the country use some form of standardized patient teaching or testing. Many other healthcare schools also are doing it either in tandem with medical schools or having their own programs. There's a lot of studies. There have been many, many studies in the healthcare education literature that look at whether or not these matter. Certainly they say clinical skills testing using simulation, and particularly human simulation, does provide unique information about learners. And some of the outcome measures actually have been shown to correlate or be associated with some of the things that happen in practice. There was a study that came out about 2 years ago that showed students that were really struggling with some issues in communication and professionalism actually later on were having those same sorts of problems in practice and were having issues with them. So I think this is actually very exciting that this work is being done, and it's being done very carefully with very high rigor as far as methodology. So one of the things when we talk about teaching with standardized patients is it's important to think about either teaching or assessment, what's available to us after the assessment is over, after the activity is over. And depending on how you structure the activity, you can have a checklist, which has, you know, content, they got these things that were critical to the case, or feedback on the students or the learner's interpersonal skills. You can get direct comments from the standardized patient. You can get comments from an observer, because a lot of times, at least in our center, which I'll show you in a moment, we have monitoring capabilities, so we can watch through a video monitor and give immediate feedback. There can be post-encounter stations, which include oral or written performance. Present the patient to me as a faculty member, and I score the student on their ability or score the resident on their ability to pull a complex case together, organize it, and talk to me about it. Or there can be written feedback in the form of a patient note, which most traditionally is the history, the physical, the differential diagnosis, and a management plan. And then I can read those and say, you missed the point, or this is fabulous, you really get it. And finally, there are video recordings. And using any combination of these, we can then do an extension out of the actual interface with the SP to see what the learners are understanding, what the learners need feedback on, where they need improvement. We can watch videos together and help them grow. The debriefing is probably as important as the activity itself. So just to do the activity, give a student a score, and have them walk away from it is not going to be nearly as beneficial in the learning process as it is to do some debriefing with the learner after the fact. So what I'm going to challenge you to do is think creatively. I've really focused on the medical model to give an overview of a standardized patient program, but I also want to show you some other ways, even at UTMB, that we're using standardized patients before we do this demonstration. Our physical therapists have gotten quite excited about the use of SPs. And in the physical therapy role now, the one thing that we're doing is testing the student's ability to do range of motion to a very precise degree, and also to do motor strength testing. The SPs are trained very, very carefully for this so that they don't move a limb beyond where it's supposed to move. And so as the SP program, this has been a lot of fun for us because it's given us new challenges on saying these are the limitations of what you can do when you're performing this case. But student after student after student goes in, does the joint movement, measures the joint, and they come up with the same reading, and that's how their faculty know that they're doing it correctly. We have worked with the lay chaplain program, which I think has been a very, very exciting thing. So the lay chaplains are trained, but they have no experience with patients. So they come to the SP Center, and they have several challenging scenarios that they walk through with in the SP Center, working with the patients before they go out and actually start working with patients in the hospital setting. SPs can also serve to assess an instructor. And so this is a situation where the little girl is actually a standardized patient, and she's portraying with a standardized patient mother being a child with new onset insulin-dependent diabetes. And the challenge to the learner, in this case it's a patient educator, is to go in and teach the child how to give herself insulin. So you can see immediately a scenario like this easily translates to any age group or any type of a scenario where patient education and training is important. We do a lot of work with counseling, so either in a specific medicine model or any type of counseling can be done using standardized patients. They're trained to have a specific question, a specific problem, and then the counselor comes in and works with them, and the SP can give them feedback on, you know, there were really important things in my story that you didn't discuss. There are important issues that I have that we need to talk about. We've worked in rehabilitation, sort of teaching, so the woman who's seated and the woman in the blue shirt are the mother and the daughter-in-law, and she's being taught how to help her get up and ambulate. And the person who's doing the teaching would be the physical therapist or the occupational therapist, while the third person is looking on saying, you did that really well, you were clear, or the SPs can give the teacher, in this case, teaching the patient and her daughter how to do a skill. The SPs can be trained to give feedback. We do issues with end of life, where a hospice care team can come in and practice doing a discussion with the family or a discussion with the patient about end-of-life issues. We're not doing this, but there's another program who has done organ donation training, where they actually have the SP and then the family, and they go in and they talk to the family about organ donation at the time of death. All of these things that are challenging and difficult to do and nice to learn in a safe setting where feedback can be given in a supportive way. We've used SPs to train physicians here in telemedicine. So the SP that's on the screen is actually sitting in the room next to us when we were doing the telemedicine training. And then she can come back in and say, you know, this felt really good, you seemed really disconnected, etc. So the sky's the limit. And so what I'm saying is be creative. Think about what your educational needs are. Think about what you want your learners to be able to demonstrate. And if it's done with a human being, it can be done with an SP with a little creativity. So our SP Center, you don't need a center to do this. You need space. You can use a clinic space. Before we had our center, we just used the clinics. We have 4 hospital rooms and 8 clinic rooms. All of our rooms have 2 cameras, a stable camera and a pan zoom tilt. We have in-room computers so the SPs can provide feedback immediately in electronic format, and then that gets beamed to a central place. So by the time the learners are ready to go, we have information for them. Student work areas allow the students to do post-encounter stations so they can write a note, they can answer multiple choice questions, they can look at x-rays, they can interpret laboratory findings, and this can all be done electronically with feedback. So again, we can see whether they're closing the loop in their thought process. We monitor from a central monitoring room, watching everything that's going on in the center, or we can monitor through one-way glass outside the rooms. And either way allows direct and live watching of the SP, or everything is recorded and we can watch it on video afterwards. So you can see that we can assess loads of skills in these formats. Factual knowledge, do you know what to ask? Critical thinking, do you know how to put it together? Psychomotor and technical skills, the physical exam, other things that you might want to do with the patient. And then very important, how do you get the information and how do you react to the patient as you're getting it? One of the things that we also use are models, and I'm not going to spend a lot of time on this, is the other phase of simulation. Anatomical models that let you learn the tactile or the size sensation of a variety of things through rectal exams, breast exams, prostate exams, or helping a person learn how to move from lying to sitting, sitting to standing. Using task trainers for learning how to, the simplest things of taking blood pressure all the way up to inserting central lines or doing an invasive procedure. And then mannequin-based training, which is heart, lung, respiratory problems, cardiopulmonary problems that can be used for teaching and training. I'm not a person who does a lot of non-human simulation, but I'm very interested in these because of blended simulations. And blended simulations are a really exciting place where we can bring it all together. It's very difficult for a standardized patient to be hooked up to a cardiac monitor and have abnormal cardiac rhythm or have hypotension or become hypoxic, but a computer-based mannequin can do that. The complexity of it is when you have the family member, a standardized patient, at the bedside, trying to cope with the fact that their loved one is not doing well, and the person, the nurse, the physician, the therapist, whoever's working with the patient, has to deal both with the fact that the patient is not doing well and the fact that the family member is there participating and has to be dealt with appropriately and respectfully while they're maintaining the emergent health care of the family member. So some of this work is really exciting and holds a lot of future, particularly as you start dreaming up scenarios that are important for your learners to go through. Does working with simulation make a difference? The literature says yes. There's lots of literature, as I said, on SPs, and there's emerging literature on computer-based simulation. I think what we look at when we look at Miller's Pyramid are 4 stages of sort of assessing competence and performance. One is that people say, yes, I know how to do this, I get it, I have the facts, I know what it's all about. The next thing is, yes, I know how to do it. And what we're doing with simulation is definitely the shows. You can tell me you know the risk factors for cardiovascular disease. You can tell me you understand what that would look like. But now I'm going to send you in a room and ask you to interview the patient and see if you can pull it all together, and you'll remember to ask about those. You'll remember to ask about ADLs. You'll remember how important that is in the entire picture with this patient. So it's the shows that we're testing with simulation, or teaching or refining with simulation. I'll send you to these resources that are at the very end of your handout. We have a homepage here, and we've maintained a rather extensive bibliography about standardized patients and simulation on that. For those of you that are very interested in standardized patients or patient simulation, there is an international organization, and the website is up there. I think I'll stop for a minute, entertain any overall questions, and then we'll move into the demonstration.
Tony, do you want to start on your end for questions? Anchorage, was there something to that? And I'll get,
Yeah, you can press the question.
oh, he's going to defer to you. Okay, so you may have to speak up. Can you hear all right?
Yeah, we're good.
Yes, we can hear you.
The other side. Okay.
That's not so much a question, it's more an observation. When you were talking about the challenging interviews, where you, it was interesting to me to observe the interpreter, the use of interpreter and using a family member, which I think that it's pretty challenging for a parent to wear two roles, being the father or the mother, who I think it was the father who was interpreting, and having the two roles being the father of the patient as well as wearing the hat as an interpreter. And I would think that it would be worth considering having a professional, qualified, competent interpreter as opposed to a family member. Anyway, that's my comment.
Okay, and I appreciate that. And actually, that is one of the pieces of feedback that comes out with that particular scenario. Was this the best way to have this experience for the family? How could this have been done differently? It opens a huge discussion, and the students do have exposure in another setting to the use of a professional interpreter versus a translator. So somebody who can really take all the information that's coming along and interpret it and then provide it in the appropriate language to the family. We currently are doing that in the pediatric clerkship, actually as a teaching experience, where we have a young mother who's she speaks very, very little English, and she comes in with a translator, and they go through the scenario, learning both how to use a translator and to make sure that the information is being conveyed. So I appreciate your comment, and I think one of the learning points of that large group scenario also is that you really should, particularly in a challenging situation like this, have a proper translator and non-family member translating.
I have another observation in response to your statement about the difference between an interpreter and a translator. An interpreter is going to be the verbal person who interprets the word, and the translator is going to be the person who translates the written word.
Okay.
So as far as, even if the family member is not a professional interpreter, they're still an interpreter.
Okay.
So, yeah, so anyway, that was just another observation.
Okay, thank you.
Yeah, I was wondering, had any quantifiable data been collected yet that displays, I guess, quality of care outcomes or continuity of care as a result of standardized patient practices?
It's a little difficult to jump from if people have exposure to standardized patients in training, do they take those skills on to practice? I think there's clearly data in the non-human simulation literature that talks about learning a skill, and that repetitive practice in a simulated setting helps with learning, not really to the point of mastery, but certainly improving the speed with which the person learns that skill. And particularly, I'm a gastroenterologist, and so we've been very interested, for example, in the colonoscopy simulator. And there's been a lot of work that's been done looking at if you put a student on the simulator, or you put a fellow on the simulator, and you let them do repeated procedures on a simulator, by the time they get to an actual patient and go to perform the procedure, their technical skill is much higher at that point than it would be if they had not been working on the simulator. I would tell you that it's going to be difficult to say, does learning on a standardized patient translate to a healthcare outcome, because there's so much confounding information that happens. These are meant to provide practice opportunities for learners, and particularly things that are, in the beginning, foundational skills, but as you move through and as you start doing more challenging things, to maybe give them experiences with things that they're not going to see very often, or that are more difficult to learn that you want to do several times to start feeling more confident or more skilled, I would use, again, the example of delivery of bad news, which is never easy. Doing it several times with a standardized patient, getting feedback, getting corrective feedback, makes it go more smoothly, I think we can say, when you're finally in a real patient encounter. And so that's not a direct answer like there's a statistical p-value that I can tell you about, but the work that's been done in this area really does support that simulation makes a difference.
In front of us, but if we all shift our vision over to the left, we can see you in the smaller screen. So why don't we begin, and we'll wait for hopefully the tech person will come and get us full screen with you. Thank you.
Okay, thank you.
Okay, so in the interest of staying within camera range, I'm going to start this scenario in the seated position. Normally when we would do a teaching scenario, we would have the patient, even if we were in a classroom setting, which this is mocking now, we would have the patient seated, we would have the student or the learner walk in and actually do an introduction. I have a mixed audience in here in Galveston, and they have a mic, and they're going to actually also be part of an interdisciplinary discussion that we have about the patient. I'm going to start this interview, and then we're going to start and stop. And when I take a timeout, I'm going to ask for help. I'll come back, I'll continue the interview. I'm probably going to ask for help a couple of times. And then at the end, what I'd like to do is ask everybody who's at distance to begin to be prepared to do a debriefing of the encounter. And from your own perspective, regardless of what your discipline of focus is in your professional or your educational career path right now, I'd like you to say, well, from my perspective, these would be things that would be important to know. If I was doing this with Mr. Cranston in the Standardized Patient Center, he would probably already be in a gown so that I wouldn't have to take the time to ask him to change. I'm not going to do a physical exam for purposes of this demonstration. So I would know coming into the room that my patient's name is Mr. Kerry Cranston. He's a 71-year-old man who came to the clinic today because of a headache. This is all that I know about him. This is all the information that would have been on a door sign. I would probably know that his temperature is normal, that his respiratory rate is 14, that his pulse is about 88, and that his blood pressure is 146/86. And I would walk into the room with that information. So we'll begin the interview. When I get stuck, I'm going to stop. And I'm going to turn and start asking for help from my local team here. And then, again, we'll turn and extend this more openly. So, Mr. Cranston, my name is Dr. Sauter. I'm one of the physicians working here in the clinic today.
Hi.
What can I do for you today, sir?
Well, my headaches are really bothering me.
They're really bothering you?
Yeah.
Tell me a little bit more about what's actually been going on with your headaches.
Well, I had these headaches, and they're getting worse, and they're really bothering me.
Okay. What do you mean by they're getting worse? Describe to me what you're feeling.
Well, it's like a vice, and it throbs.
And where is the vice?
It's like right at the temples up here.
Okay.
It goes all the way around back here.
Okay.
To my neck.
Does it start in your temples and move back, or is it just like a band around your head?
It's all around.
Okay.
Yeah, it's all around.
And when did you first notice this?
Oh, I've had headaches, off and on for years. It seems like they started getting worse about a month ago.
A month ago.
Uh-huh.
Okay. Was there anything different going on in your life a month ago?
No.
Nothing?
Uh-uh.
And in what context did you start noticing that the headaches became more of a bother? You've used the word bother several times.
Well, it seems like they kind of come on more often in the afternoons.
Mm-hmm.
And they seem like they're getting worse. That pain's worse.
Pain is worse.
Yeah.
Okay. When you start noticing the headache, does it just come on suddenly or does it start to build up?
Comes on pretty quick.
Comes on pretty quick.
Yeah.
And how long does it usually last when it starts?
Oh, I'd say anywhere from 1 to 4 hours.
Good grief.
Uh-huh.
And what have you done to try to feel better with these headaches?
Well, I tried Motrin,
Uh-huh.
and I tried Tylenol,
Uh-huh.
and that seemed to work a little bit, but not a whole lot. But it seemed the thing that seems to work better more than anything is if I just kind of get off in a room, you know, and relax and turn the lights off.
Okay.
That seems to help more than anything.
So is the light bothering your eyes when you have these, or?
No, it
Not
just
really?
seems like it's better if I turn the lights down or low or something to help me get past it. But the light doesn't make it any worse. It doesn't seem to me like.
Okay. When these headaches come, do you get any other symptoms?
Like what?
Nausea, dizziness?
No.
No, you haven't noticed any of that. Is your vision normal with the headaches?
Yeah.
Yeah?
Yes.
How about your hearing?
Yes.
Okay.
Yes.
Do you have any pain when you chew?
No.
No, not at all. Okay. So let me go back and see what you've told me that you've had over the last month in particular. You've had headaches previously, but particularly over the last month, you've noticed that the headaches are getting worse, maybe a little more frequent.
Oh,
They're
yeah.
interfering with your lifestyle. Is that a fair interpretation of what you've
Well,
told
it
me?
certainly interfere with my job, you know, when they happen in the afternoon, because I'll be working then.
Okay, what kind of work are you doing, sir?
I'm a data entry person.
Okay. Okay. So you're still working regularly? You still go to work every day?
Sure, yeah.
Okay. And you're working at a computer all day long?
Yes.
Okay. All right. Okay, time out. Okay, so at this point, I'm lost because I don't know anything about headaches. So I'm just kind of trying to figure out where I would go with my patient. So I'm sitting in a classroom, I've got a group of learners, and I have a group of learners from different disciplines. So I'm going to turn to them and say, what do I need to ask this patient? What should I ask him next? Where do I go?
I could have missed the statement by him because I had to be out for a few minutes. But have you asked him about his sleep patterns?
No, I haven't.
Being awakened at night?
Okay, that's a good question.
Another one is he wears glasses. When was the last time he had his vision checked?
Okay. All right. What else would be important to know?
I'd like you to ask him if he's had any major life events.
Major
recently.
life events. Okay.
6 months or so.
Okay. What else?
I'd like you to ask him, since they happened at work, and it seemed like you were assuming initially that he was maybe retired, if you would ask him if there's been any change in the setup at work, the lighting or configuration of his workstation.
Okay.
And if they're better on weekends when he's not going in.
Okay. Those are very helpful. Thank you. Any other information that would be useful to gather about the acute headache? I obviously have other medical information and would be other lifestyle things I need to know. Yes?
Has he ever had any sort of injury to his neck, a car wreck, an accident?
Sure.
He's getting a tingling in his, any neurological symptoms in his arms or his spine.
Does he eat lunch regularly?
Okay. Because they're happening in the afternoon. So.
Well, I was thinking about back to lifestyle. Does he skip breakfast? You know, what are his eating patterns? And also, what are his drinking patterns?
Okay.
That could be or the amount of sleep, not only his sleep patterns and the amount of sleep he gets.
Another one was the heavy coffee drinker. Anything changed in his caffeine intake?
Drinking of anything.
Or any change in his diet.
Okay. Anything else?
Anything like weight loss.
Okay. Constitution symptoms. Okay. Let me start with these, and then I'll probably be back for more. Okay. I'm going to chime in with you. So Mr. Cranston, as I've taken a moment to reflect about what we've talked about, I do have some other questions that I'd like to ask you.
Okay.
I'd like to understand a little bit about your lifestyle and your work environment. So I'd kind of like to ask you sort of a little bit about your day.
Okay.
So when you get up in the morning, what time do you go to work?
I get to work at 9.
At 9. Do you eat breakfast? Are you a breakfast eater?
Oh, yes.
You eat, and do you eat every morning pretty regularly?
Oh, yeah. Oh, yes.
Okay. Do you drink coffee in the morning?
No.
Have you ever been a coffee drinker?
No.
Do you use any caffeinated beverages at all?
Well, I drink herbal tea.
Okay.
I don't know if that has caffeine in it, but it's just herbal tea. That's
Most of
all
the
I
time
drink.
it doesn't, yeah. Okay, so you get to work at about 9,
Yes.
and then you're at the computer, working at the computer.
Yes.
Has your computer station recently been reconfigured? Has the lighting been changed? Have they gotten you a new monitor? Has anything about the work itself been changed?
No. No.
Okay. And I noticed that you wear glasses. When was the last time you had your eyes checked?
Probably about a year ago.
Okay. How do you feel if you're just reading the paper or doing work at home? Do you feel like your vision is okay, or are you straining to use your eyes?
No, it's okay.
Okay. So you go to work, you get to work around 9, you're at the computer. There hasn't really been any change recently. And then do you take a break at lunchtime?
Sure.
Okay. Do you eat lunch?
Sure.
And do you eat lunch pretty regularly, pretty predictably?
Oh, yes.
Okay. Any unusual foods that you've added to your lunchtime meal? Any change in maybe, do you make your lunch and take it, or do you order out?
Both.
Both?
Yeah.
And has that changed at all? Are you doing anything differently?
No, I don't think so.
Okay. One of the things to think about is the pattern of this headache. Do you get them at home on the weekends as well?
I have.
Okay.
I have.
When you're, and I'm sorry, I'm making an assumption that you work Monday through Friday. Is that correct?
Yes.
Yeah. Okay. So on the weekends when you're at home, are you doing computer work at home?
Maybe.
Maybe?
Maybe not.
Maybe not. So
Maybe
you're
not.
not pretty routinely trying to get stuff done at the house as well?
Well, you mean work stuff?
Yeah.
No.
Not particularly?
No.
Okay. And so, but you still notice the headaches sometimes at home?
Sometimes.
Okay. Have you had any injury to your neck or your head recently?
No.
No?
Mm-mm.
Okay. Have you ever been in a car accident and experienced whiplash or any sort of a head injury?
No.
No? Okay. Tell me a little bit about your sleep pattern.
Well, I've been missing sleep lately.
Been missing sleep. Can you
Yeah.
tell me a little bit more about that?
Well, I wake up kind of early in the morning, and it seems like I can't go back to sleep.
Okay.
Now that was before. That started happening before this headache.
Before the headaches?
Yeah, about 3 months ago. That's kind of been going on.
Okay. So what's your normal sleep pattern? When do you usually go to bed?
I usually go to bed about 11 o'clock.
Okay.
Yeah.
And then when are you waking up, typically?
Usually about 7.
Okay. But now with this change in your sleep pattern, you say you're waking up at 3 or 4?
3, 4, 5.
Okay. How many
like
nights
that.
per week does that happen?
It's hard to guess. Seems like it's too many.
Okay.
I would say probably maybe anywhere from 3 to 6 nights a week.
Goodness. All right. When you're waking and you can't fall asleep, do you have thoughts in your head that are bothering you, that are keeping you awake, or is it just that you can't sleep?
Well, one of them's that I can't sleep. That's one of them. But I can't, I can't really, it's just different things.
Okay.
It's different things like at work or, or something like that, because like I'm always entering information,
Okay.
and sometimes interpreting it, sometimes passing it on to other people for them to interpret. Sometimes I think, well, did I put that in? Did I get this information and did I put that in?
Okay. Are you having problems with your concentration at all?
The pain.
The pain is interfering with your
Yeah,
concentration.
it makes it really hard to concentrate.
Okay. All right. One other question, I want to ask you a little bit about your personal habits. Do you use tobacco?
No, I never smoked.
How about alcohol? Do you use any alcohol?
Never.
Have you now or in the past ever used any street drugs?
Oh, no.
No?
I've never done anything like that.
Okay. And overall with your health, have you had anything that you've noticed in addition to the headaches, like weight loss?
Yeah.
You have lost some weight?
Yeah, I lost 5 pounds in the last 3 months.
You have? Have you been trying to lose weight?
No, I tell you, it's just that I don't, my appetite seems to, I don't have the appetite like I used to. So I haven't been eating like I used to.
Okay.
I don't know if that's the pain or, you know, something else. But
okay.
I just haven't been eating as much.
Okay. I want to ask you just a couple questions about your other medical issues. What other medical problems do you have?
Well, I went, after my wife died, I went to the doctor about depression.
Okay.
And that's the only other thing that I have.
Depression?
Yes.
How long ago did your wife pass away?
About 12 years ago.
Okay. And have you been dealing with depression since that time?
Put me on Zoloft.
Zoloft?
Yes.
Okay. Is that the only medication you take routinely?
Yeah. Yeah, what, the aspirin and, you know, that I told you about?
Okay.
Other than that, yeah.
Okay. Do you use any herbal products, or have you gone to any sort of other medical, other healthcare providers?
Well, I guess sometime during this past month when these things got so bad, I did go to a chiropractor.
Okay.
And he, you know, they give you whatever they call it, adjustment, whatever it is.
Okay.
It didn't seem to help.
It didn't help.
And I had some stuff that my wife had before she passed away, because she was really into it. This herbal stuff, Tiger Balm.
Tiger Balm.
Yeah, and peppermint oil.
Okay, and have you been using those?
I tried, but it didn't seem like that does very much good, you know.
Okay. Time out. I'm going to turn back to you now and say, I'm feeling like there's clearly areas of his life that I'm not exploring very well, and I'm going to ask my learners here for help. So from all of your perspectives, what data would be helpful to know at this point? Go ahead.
I always like to ask the patient, what do you think this is?
Okay.
Or could be causing it.
Crying spells.
Okay.
Sadness.
So mood. Yeah, okay. What
A
else?
little bit more about the anxiety. He said he was worried about his, if the data was entered correctly. This may be something new, a technology. If this is a new job, this may be something he feels very, not inadequate, but worried about.
Okay.
Understanding.
Okay.
I have,
Go ahead.
pardon me.
No, please, go ahead.
In keeping what she says, I suddenly had the hunch that the data he's translating could be sensitive enough to affect lives.
Okay.
And there may be a lot of anxiety over if I didn't understand it correctly. It might have to do with the military.
Okay.
But that
So something related to
could be
the...
that, or could be medical data, but it has to do with something intensely personal that could affect another human being.
Okay. So doing it wrong could be a problem.
Yes.
Okay, that's a helpful thought for me to process.
What about his social support? He mentioned his wife dying 12 years ago. Does he have any other family, close friends? Do anything recreational? Did his dog die a month ago? I mean, I know you asked if anything changed in his life, but did something happen that might cause a recurrence of grief?
Okay.
And he said he's been on this for 12 years. The Zoloft, that's a long time.
Does he volunteer or fill his time with anything fun and recreation?
Okay.
Well, the only way he's going to stay on Zoloft is to go back and see that particular physician to get those prescriptions refilled.
Okay, that's a good point.
So what has he learned from somebody else?
Okay, so when was the last time you saw his doctor?
Sure.
Okay, time back in. Okay, I'm sorry, Mr. Cranston, there are just so many things as I reflect on your problem that would probably be helpful to talk to you about. I want to ask you a little bit about your mood in general. How would you describe your mood?
Well, I don't seem to have, like as much energy as I used to have.
You don't have the energy.
Well, because this pain just
The
takes
pain.
a lot out of you.
Right.
I don't seem to have the interest in doing things that I used to have.
Okay. Do you find yourself emotional at times? Are you having crying spells, or are you having strange spells where you feel really energized ever?
No.
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 Neither of those? I asked you a very long question, sorry. I don't know if you can tell me more about the data entry that you're doing, but you seem concerned about making an error. Is the data particularly sensitive that you work with?
No.
It's not?
No. I tell you, I work for the Golden Tata Corporation.
Uh-huh.
And they run several Hooters operations.
Okay.
And it's keeping up with the inventory and the sales at each location.
Okay, so it's a sales and inventory and getting all that information together.
Yeah, and it's just...
It's a lot of data.
I mean, it's dull and it's tedious stuff, but
Okay.
I've done it a long time, and I like to do it well.
Okay.
And I like to keep on doing it.
Are you worried about losing your job?
Not particularly, but with this pain, I'm worried that the headaches keep up, and I'm going to mess up on the job.
Okay. One last question I'd like to ask you before we shift into a more extensive physical, and I want to do a mental status exam on you. What do you do for fun on the weekends?
Well, I used to go out, and I still sometimes go out and just walk on the beach.
Uh-huh.
And I used to be pretty active with this group at the church that I go to.
Okay.
But I just don't have a lot of interest in doing that. And ever since these headaches have gotten worse, it's just harder to be around people and.
Okay. Do you have friends?
Yeah, I've got a group kind of at the church that used to do a lot of things, and I used to go out with them before all of this.
Okay. Okay, time out. All right, so in the interest of time, this interview could go on and on and on, obviously, because there's a lot of things that are sort of unfolding as we're talking. I would, as the physician, want to do a mental state exam on him. I would want to make sure he's oriented, that everything's functioning the way it would. I would take him through a complete neurologic exam, would want to examine his eyes, etc. And at this point with a group of learners, I would say, okay, what should I do in the physical? And we would list those all out and talk about them, and then we would actually do them. I want to shift the discussion now, though, and turn to you as the learners or the participants, because we would do this as a group event, and say, do you think we're getting to the soul of the problem as a team? Are there things that are going to be critical to know about? Just as I'm talking to you, I would raise my hand and say, I didn't even really ask him what his level of function is at home. Does he keep his house? Does he pay his bills? Is he in trouble? Those would be really important questions, particularly in this 71-year-old man who sounds like he has some overlaying depression and maybe some anxiety and some sleeplessness, etc. But where are we going, and how's this interview going? I would now turn to you and ask for some feedback.
I think you've learned a lot. He's got the symptoms, and you asked some questions of the screen for organic disease. He's profoundly depressed, and you're onto that thing. So I think you learned a lot. I don't think there's any big gaps, or things would come out as you examine the patient.
All right. And then I would ask you specifically to give me, the learner, feedback on what could I do better in my interview. What have I done that you're noticing? Are there things that would make me a more effective interviewer, particularly for this gentleman?
I think that you did very well, but more open-ended questions where he doesn't just say yeah or no, and describe a typical day for me.
Okay.
Describe a day when you don't have the headache. What are you doing?
Okay. So more open-ended questions, more tell me your story rather than more data gathering. Okay, that's helpful, thank you. What else?
A little bit more welcoming him to dig deeper. So when he says something somewhat interesting to you, maybe leaning forward just slightly and saying, can you tell me more about that?
Okay, so maybe my body language could have been more facilitating for the interview than it was.
It's sort of like I'm going to get, your body language seemed to me to be saying I'm going to get to the next point.
Okay. All right? Okay. We'll stop and step back now from this and sort of open for questions, comments, but you can see the process that we're going through now, and I would certainly love to invite questions from the outside centers.
Karen, this is Rosella
Yes, ma'am.
in Anchorage. Your learners, what kind of disciplines are your learners coming from?
I'm in health education.
Health education.
I'm a major gift fundraiser for UTMB.
Okay.
Internal medicine.
Nursing. Spirituality of aging.
Could you hear all that?
Yes, we did.
Okay.
Thank you very much. Are you, because it looks like the bewitching hour, but are you up for a few quick questions on this case?
I'm more than delighted to entertain questions. I understand if people have to go, I'm not offended, but certainly I can be happy. And Mr. Cranston can also answer questions. Mr. Cranston's been with the SP program off and on since the mid-1980s. He's been there longer than I have. So he has very good insight into what it is to portray a patient, and so we can answer questions about the scenario. We can answer questions about whatever you'd like to talk about. Okay.
Thank you, Mr. Cranston. I certainly appreciate your time and your expertise in helping us here in Alaska understand unique problems and situations that older people have and how best an interdisciplinary or interprofessional team can be utilized. We do have a question here from Anchorage.
Go ahead.
Yeah, Mr. Cranston, I had one. You have feedback on scenarios for the position.
Feedback.
Anything that might have been helpful for her to ask. Anything that would have been helpful for her to ask you in terms of questions or.
Well, of course, we didn't. I think what she's got to do, first of all, is to rule out if there's any kind of organic illness or anything like that that's going on, and determine whether that. And that, of course, we didn't do because we couldn't very well strip down here to a gown so that she could examine me. Anyway, so we need to rule that out first of all. But as far as the content of what she covered, I think she covered most of it, pretty well. There wasn't anything that was buried in there that she didn't really kind of get out.
Thank you, and thank you all of you for this opportunity.